Okay. All right. Good morning, everyone. This is Professor Irene Dunham, and this is a comprehensive review for exam number 2, or how I like to put it, it's a prep. We're getting you ready for next week, okay? Because you're going to take exam number 2, and all my colleagues want you to be successful. I'm going to start out by just thanking my colleagues for all their work that they have put in to make this exam prep available. Okay, I am now going to start. I'm going to start by sharing my screen, and be sure to have a notebook so you can make some notes, and then also have your textbook, okay, if you can have it. All right. Alrighty. So now you all be able to see my screen. So we can start here. Now, Professor P has so nicely put together a PNR 203 Exam 2 concept guide. Be sure that you print that up and that you go down the list. And the first one on her list was the culturally appropriate care. Now that is right in chapter 6 on page 123. And so I would just go ahead and tell you to look over that and know that nurses, we have to be culturally diverse and respectful to all cultures. Okay. All right. So now, chapter 6 is nursing care of the mother and infant during labor and birth. I'm sure by now you have done all the key terms on all the chapters. So this is time now that we're going to just do a review of the different concepts. Okay, I'm going to start out with preeclampsia. Preeclampsia. Now, these patients are quite ill. They have high blood pressure, and so they need some quiet, low light environment. Now, you're going to have to pad the side rails, and you probably say, why I'm going to do that is because they could go into eclampsia very easily. And then we always pad the side rails to prevent what? Injury to our patient. And then these patients have limited visitors. Again, these type of ladies, they're ill. And it is a complication during pregnancy. So you can't have the entire family in the room, so you limit visitors. I'm going to minimize stimulation, and I'm going to maintain safety and airway if seizure occurs. I would go ahead and circle that or write that down. You always want to maintain safety and airway if a seizure occurs. Now, how are we going to prevent her from going into eclampsia, where the difference between preeclampsia and eclampsia, let me clarify, is that in eclampsia, you have the seizure. You have the central nervous system that has been irritated. So we're going to want to prevent the seizure activity. So we're going to give her medication. Now on the side here, you see right here, a bag of magnesium sulfate. It's a high alert drug. So therefore, it's in red, as you can see. And so that is the drug of choice, is magnesium sulfate. Now, during the pregnancy, it might give her, she might be managed with some hydralazine, labetalol, but in order to prevent a seizure, we're going to give her magnesium sulfate. These patients are on continuous monitoring, and the only cure for preeclampsia is delivery of the baby. Okay, so these are pretty good, like all but apply question for preeclampsia. So what would the nurse do? And so you would make sure you have a quiet, low light environment. You have your side rails that are padded, limited your visitors, always minimize stimulation. So how do you think you would minimize stimulation to a patient? Well, how you would do that is you make sure that you do all your nursing activities in and just, put them all together. So you don't go in and out of the room, and so when you go in and out of the room, you are stimulating the patient. So I want her to rest. And so that's what you would do. And of course, always maintain safety airway if a seizure occurs. Okay. And again, what's the drug of choice? Magnesium sulfate. It prevents seizures. Remember that. I would really remember that. It prevents seizures. Okay. So that's preeclampsia in a nutshell. All right, the next complication that we studied the last couple of weeks have been about bleeding. All right, so these are two complications that can occur in that placenta. So you have two. You have placenta previa and you have abruptio placentae. Okay, they both cause bleeding, but placenta previa, now let's just review what that is. Basically, what happens is that over the cervix, the placenta is presenting. It's right there. And so here's your cervix, and as you can see, and then the placenta will be down there. Placenta previa is painless bleeding. So if you haven't written that down, that would be a good description, painless bleeding. And the uterus is soft, is non-tender. And, the fundal height might be increased for gestational age. Now, you're probably thinking, how does that work? Is because what happens is the placenta is low lying, right? So what happens is that it pushes everything back way high. And so her fundal height might be skewed. It might be high for the gestational age. And again, placenta previa is silent bleeding. Is painless bleeding. Okay. Now, on a placenta previa, the nurse, if she was diagnosed placenta previa, you don't do a sterile vag exam. And if a patient comes into your triage area, I wouldn't, if she had bleeding and she had painless bleeding, you think I would do a sterile vag exam? No. I would report these findings and I would get an order to have this lady have an ultrasound if she has not been diagnosed with a placenta previa. So you don't want to put your fingers in there because what happens is that you could go right through the placenta. Okay. So now on the other hand, and you can see the picture here, the partial placenta previa. And they have, you have partial, you have marginal, and you have complete. Okay, now, how are you going to take care of this lady? Well, she has to have a C-section. Okay, you're not going to deliver her. You're not going to do you do not do an induction. It should be a C-section. Okay, now on the other circle here, we have abruptio placentae. Now this one has severe abdominal pain. So write that down, severe abdominal pain. And what happens is that she comes in to your triage area and she's in pain and her abdomen, you put her on the table and you see her abdomen is like a board-like and it's rigid. And it really is. It's very hard. And so and this can be from an acute onset. So what do you think would cause a placenta previa? Well, maybe she was in a car accident, or maybe she was a victim of IPV, intimate partner violence. And so she had some kind of blow to her abdomen. She fell. She had a hard fall. And that can happen. And you can see here the placenta, and you can see the blood, and you can see how it's abrupting off the wall. Okay, so that would hurt. Remember, anything that abrupts, it would hurt. So it's pulling right off that endometrium, and so therefore, it would really cause a lot of pain. So you can see the difference. This one here is an obstetrical emergency because you got to get this baby out because time is of essence. Okay. So Everybody, placenta abruptio, you're going to what? You're going to section this lady. And it usually is an emergency C-section. Okay, because we gotta save our little guys. Okay, so then that's on placenta previa and abruptio placentae. All right. Now moving right along to another problem we have during pregnancy is spontaneous preterm birth. Now, what happens is that they went into labor too early. Okay, so you have signs and symptoms, and what happens is that the cervix starts to get real soft. We call that effacement. And so the cervix gets soft, and then the dilation starts to also happens. And what happens is that if they get below more than 2 centimeters, it's really tough to stop this labor. All right. So what they experience, and this could be a good question, they experience pelvic pressure. They experience a dull backache, and the uterus gets tight. So again, they experience pelvic pressure, a dull backache, and uterine tightening. Now, what happens is that we try to stop them because we don't want these babies born too early. So, because babies have their biggest job at birth is what? To breathe. Okay, so what kind of medication am I going to use? Well, here it is again, magnesium sulfate. And that's because it works on the central nervous system. And so this one, just remember, we just used it in preeclampsia patient. And now this medication also works to help with preterm birth. All right. So we have an IV in her. We're giving her the magnesium sulfate. We got a blood pressure cuff on, got a pulse oximeter on. We got the fetal monitoring. We're always monitoring baby, so we know what's happening. So we're able to stop her. Yay. We don't want babies born at 26 weeks. So what's going to happen is that she has to have some lifestyle modifications. She has to restrict her activity, bed rest. Now, she's a single mom. That could really put a big financial burden on her. So then that would cause her to have more stress. But this is what we want to do. We want to make sure we keep these babies in utero. And then we always want to suppress the uterine activity. Some of these moms just have what we call irritable uteruses. And so the uterus just keeps contracting. And so we can use also some other tocolytics. Now, tocolytics is a group of medications that is used to stop labor. Just like over here on this little box here, it says uterine relaxants. That means it relaxes the uterus, and they're called tocolytics. Now, if you see toco, that's actually one of the fetal monitors we call toco, is to actually pick up the contractions on the fetal monitor. So that's why it's called a tocolytic. And I love this. It says, it's not my time. No, it's not. You are not 40 weeks gestation. You are here 30 weeks. So it's not your time. And these are different medications that is like a mnemonic here that tells you with the indomethacin is the NSAIDs, and then you have your channel blockers, magnesium sulfate, and terbutaline. Now, all right, so here we go. Here they are over here also, and all of them do a really fine job in suppressing the uterine contractions. Okay, now with terbutaline, let me tell you that you need to monitor mom's heart rate because she can get tachycardia. And the nephritine here causes hypotension. And so when I gave my patient terbutaline, I'm watching the heart rate, and she can feel a little jittery. That does occur. And so you have to make sure that we're educating the patients on this. And then sometimes they do is it could be they went into preterm birth because of infection. And the biggest one that throws patients into preterm birth is a urinary tract infection. And so we give her antibiotics and get that under control, get her to drink lots of water, flush that system out, and sure and behold, the uterus what? Remains relaxed. See, the bladder, as you probably learned in your other chapters, the bladder on the anatomy and on the anatomy scan of a woman, the bladder lies right underneath the uterus. When the bladder gets inflamed, it with maybe some bacteria, and she ends up with maybe cystitis, the uterus will go ahead and start contracting because it's getting irritated. So it kind of makes sense. So that's why at every visit we are watching on the dipstick, the urine dipstick, we're looking for WBCs and nitrites because that's an indication of a UTI. Plus, if she has a foul-smelling urine, then we know that it's got some bacteria in it. Okay. So we want to give her antibiotics. Now, if she keeps contracting and we think maybe we're not going to be able to stop her, then we'll give her and administer some betamethasone. What that is, that's a glucose steroid, and you give it in 2 doses, and it's 24 hours apart, exactly 24 hours, and it's an eye injection. And what that does, that increases the production of surfactant in the baby's lungs. And so therefore, it helps to promote lung maturity. So betamethasone works very nicely, and it really does help because remember I just said the baby's biggest job is to breathe at birth. Okay, so if I can help this little guy who's being born maybe at 28 weeks to have a less harder time at birth, I want to do so. So I want to promote lung maturity. So this is what we do, and it helps. Now, I already talked about giving her administering magnesium sulfate. That is a drug of choice for when somebody's in preterm labor. Okay. And then we talked about the tocolytics. And these tocolytics too, if they're given before 32 weeks, say if I have a 30-weeker, it helps to prevent some cerebral palsy, and they're good. Okay. So they all have an aspect of them that will not harm, but would only help. And you always want to be aware of toxicity. So are we monitoring our patients? Yes. So close your eyes and imagine this patient in your labor room, and she's scared, of course, because she doesn't want to deliver pretermer. So we're going to reassure her that, we're going to use our therapy communication. We're going to reassure her that what? I'm here. I got you. I got an IV in you. We're gonna give you some fluids, give you hydrated. I'm going to give you some medication called magnesium sulfate, and that will help relax your uterus. And we have the fetal monitor on, so we are looking at not only the fetal heart rate, but we're also looking at the contractions. And then, I would palpate the uterus by taking just 2 fingers and just put it gently on top of the fundus to make sure that if she does have a contraction, it's mild. Okay, so we want to make sure that whatever we're giving, the medication, is that we get a good outcome. All right. So again, these patients, you have to be, you have to be reassuring them all the time because they are scared. And another big cause of preterm labor is also dehydration. And I live in Florida, so we have a lot of patients that come into the hospital after they've been, say, at Disney all day in maybe 95-degree weather, and they've been, having a good time, but they got dehydrated. And so then they started to contract, and then they present to the hospital. So we get an IV in them very, very quickly to get them rehydrated. That makes sense? Okay. So that's preterm birth. All righty. Now, of course, I have preterm birth. You have to go to postterm Okay. And so this is pregnancy that extends beyond 42 weeks. When you get to about 42 weeks, things start to get old inside, especially the placenta. Remember, the placenta is a temporary endocrine organ. And it's also a temporary respiratory organ for the baby. So we don't want the placenta to get old. Okay, so when it goes past 42 weeks, it starts to calcify. And if you have a diabetic mom, that placenta calcifies even earlier. That's why a lot of times with diabetics, we'd be very careful, and we do what we call NSTs, which is a non-stress test. Okay, so we got a post-term pregnancy. And so what are some of mommy's risk? Okay, well, we can have a woman that just remember they went to 42 weeks is because they didn't go into spontaneous labor. Their uterus is what? Kind of sleepy, kind of lazy, all right? And so they have more of a dysfunctional labor, and we can call that labor dystocia. That means that we probably will induce this patient and try to get the baby out. Now, when you induce, I'm going to put my patient into labor by using a drug called Pitocin. And that Pitocin is very, very strong. And I give it in milliunits. So I'm going to try to get this uterus who's been lazy to kind of wake up and to start contracting. I start getting her to put out her own oxytocin and from the pituitary and let's get going, But a lot of times what happens is that I get a contracting to be about every 3 minutes. And then my next set of contractions space out to 5 minutes. So we go 3, 5, 6, and they're all kind of erratic. And so that's what you call dysfunctional labor. Okay. And that tires mom out because don't forget she's the one experiencing these contractions. And it's just tiring. All right. Then you may have some perineal injury due to a macrosomic baby. Now, macrosomic baby is a large baby. They have wide shoulders and they have a big head. Okay. And they're just big babies. They're like from 8.8 pounds to 10 pounds and greater. Those are big babies. Okay. And you could have 11 pound, 12 pound, but it starts from 8.8 and greater. And those ones, even if you get her dilated, okay, and she's descended into the lower pelvis, you can get her injury to her perineum because of this big baby. Because not only maybe they have to cut an episiotomy, which is a cervical cut down the perineum, but all that tissue it's so soft, so it can get injured very, very easily. And then with a macrosomic baby too, sometimes we have to use some assistant devices. And one is called a vacuum extractor. And they put that right on the baby's head. And while mom pushes, the provider pulls. And so that gives a little more, counter pressure and helps to pull that baby out. They also can use forceps. And forceps are stainless steel, so they are hard on the baby's scalp head and can do, leave a little bit of a mark due to the forceps. All right. And then another maternal risk would be a hemorrhage and infection. Yeah. Hemorrhage is never good. And mom can get into a lot of trouble with the hemorrhage. There's a lot of bleeding. And for a vaginal delivery, it would be greater than 500 mLs, consider a hemorrhage for a vaginal delivery. And for a C-section, a hemorrhage is greater than 1,000 mLs. Okay. So And then also you can have a uterus afterwards that just wouldn't contract after delivery, and she would have what we call a soft boggy uterus. And you're doing fundal massage on this type of lady, trying to get her fundus to be firm. Okay. And then again, at 42 weeks and greater, you can get into areas of infection. And so now mom is sick and baby is sick. So we have to be careful with this too. And then you have fatigue and psychological reactions. Well, yeah. I mean, first of all, she's probably tired of being pregnant at 42 weeks. Okay. And a lot of pressure probably at 42 weeks because the baby has just gotten bigger. And so it does tire mom out. And two, psychologically, she's been prepared for a while now. And then she's like, okay, when's this baby coming? And probably her family is saying, when is Johnny coming? And so that has a lot to play. And also when you're doing like an induction on a 42 weeker, you have to be very careful as to, how she's going to react. And a lot of ladies have birth plans. And they, been told, don't have an induction. But if you don't go into spontaneous labor, you do need some help. On the other hand, now we have the fetal risk of being in there too long. Okay, so Johnny has to be, what I always said, he has to be evicted. Okay, time is up, baby. You have to come out, because all he's doing is what? Getting bigger. So you have this abnormal fetal growth, and that is called macrosomia. Okay. And this baby is now at increased risk for birth injuries. So we don't want to create birth injuries. I told you about the stainless steel forceps that can cause him to have marks on his scalp. Also, he could have a cephalhematoma. And what that is, that's a collection of blood under the scalp. Okay. And it's on this, like on the side of the head. And it has to, the blood will get reabsorbed, but, that's always a problem, and mom is kind of worried. And two, you have to worry about bilirubin related to that cephalhematoma. So you want to be careful. And another birth injury could be a caput succedaneum, which is on the caput, which is the back of the head. And I'm kind of demonstrating that if you can see me. And that's just a collection of fluid. Now, the difference is that it's right in the back of the head, and you see the suture line going up the middle. And so that would definitely cross the suture line. Okay, that will eventually go down too. All right. And then again, cephalhematoma is on the side of the head. So you can see that does not cross the suture line. Does not cross the suture line. Okay. So we got birth injuries. And so you can have hypoxia too at birth, and you don't want to create that. Now, also, you have an aging placenta. Remember we said about the aging placenta? And so that lowers estrogen production. So that's never good either. And because the placenta, the baby needs what? The placenta is the temporary respiratory organ for that baby too. So you want the blood flow to be good. So aging placenta would be not good. Okay. And then another cause of post-term pregnancy to do to baby would be oleohydramnios. Now, what you say, I forgot what oleohydramnios is, and is a decrease in amniotic fluid. Now, when you have oleohydramnios, you can get cord compression. Remember, the cord is just kind of floating in there, and if it doesn't have the buoyancy, the amniotic fluid around the baby, then that cord kind of gets compressed. And then what we get from that is we get those variables. And again, baby needs his oxygenation from the placenta through the cord to the baby, right? So we don't want that. And then oleohydramnios can also cause hypoxemia, and that's never good. And so we have to make sure that if we have oleohydramnios during labor, let me just kind of give you a little tidbit here. We can increase the fluid in there by using amnio infusion. Okay. Now, another fetal risk is increased risk for meconium aspiration syndrome. So say the baby had his first bowel movement in utero, you know, it's time for me to be out. I should be having my bowel movement outside, correct? So I'm still in mom. So now I had my first bowel movement in mom, inside. So this can be a big risk, and babies that are born with meconium aspiration syndrome, they are sick babies. They have severe respiratory disorders. And so what happens is that with meconium, when the head pops out, the nurse's responsibility is to have the equipment ready for suctioning. So imagine the head coming out. And so we right there, we're going to suction that baby with wall suctioning. So it's a good amount of pressure, and we can get a lot of that meconium out. Now, when the baby next contraction, the contraction pushes the baby out. Okay. And what happens, I don't stimulate the baby. I bring the baby over to the radiant warmer, and then I have respiratory, and I have a NICU nurse there. And respiratory will go ahead and intubate the baby, and then they'll do a more deeper suctioning. Excuse me. That will help with decrease that risk for meconium aspiration syndrome. Okay, and then I have another big fetal risk would be hypoglycemia, which is low blood sugar. So anything below 45 milligrams per deciliter on a term baby would be hypoglycemia. And then you could have a jittery baby at birth because of the hypoglycemia. So there are fetal risks, as you can see, to a baby that is going to be post dates. And that's what we call it, post dates. And this is post term. Okay, so I hope this helps you to understand that this is never good either. So mom should just go into labor around 40 weeks, and that would be great. Okay. But you know, that doesn't always happen. So we are ready to do any kind of intervention in the labor room. Okay. So this is interesting. This is called precipitous labor. Now, you probably heard this in your lecture, and that's labor and birth that lasts less than 3 hours. Wow. So some people say, oh, that's great, just get it over with. But imagine you got what we call hyperstimulation of the uterus. And so instead of those contractions being like, 2 to 3 minutes, they're every minute, lasting a minute. So there's no time, there's no relaxation time between contractions. So just kind of, you can draw these like hills on your paper and just go whoop, go up and down, up and down, up and down. And that would be hyperstimulation of the uterus. Now, and that's another, and you can see hypertonic contractions over here. Okay, so it does have some complications. You could run into, with the fetus, you could have hypoxia. Okay, now don't forget, every contraction, what happens to baby? I have decreased oxygen flow, right? Because everything's being compressed when that uterus gets really hard. So what happens is the fetus actually holds his breath, okay, during that peak of that contraction. It goes, oh, okay. And so just think how many times you could hold your breath and be okay. All right. So that's why he can get hypoxia. And then you have intracranial trauma. due to rapid birth. Now, yeah, because what happens, he's coming down the birth canal, the passageway, really fast. Okay. And so remember, his head, it has soft tissue because the head is able to what we call mold into the pelvis. So now I'm coming down and it's like I'm like a roller coaster. Maybe you've gone to Disney or a theme park and you have that big drop. I mean, that's kind of like this baby coming down the pelvis is fast, and he's hitting bone, and he can have an intracranial bleed due to coming down that passageway a little bit too quick. Okay, now mom's complications. Okay, well, mom can have a uterine rupture. You know why she can have a uterine rupture? Because of this uterine tachysystole, which is hypertonic contractions. And that uterus is just firing up one after the other. And eventually, what happens is that it just opens up, so much pressure. And so you can have a uterine rupture. That's never good. And then you have lacerations or a hematoma in her perineum because she everything's happening so quick. The head came so quick and just created hematoma. A hematoma in the vaginal area. Let me tell you something. It is very, very painful. They have a hard time walking, hard time urinating, and so we don't want to create this hematoma. And then you can have lacerations. She can tear because the head came so fast that the tissue, the perineal tissue, didn't have time to really soften up and what to expand open. So that can happen. And then you could also have what we call a postpartum hemorrhage. And again, she could have a very soft, boggy uterus. And the fundus now, because what do you think? The uterus has been firing all this time, one after the other, one after the other. Here it is. And all of a sudden now, the baby's delivered, so the uterus goes, I'm done. Okay. And so you have this soft, boggy uterus, and you could have a massive amount of bleeding after this kind of delivery. So we try not to. These are, these are complications that can really happen. And so you got to be aware that somebody delivers like this, that you could have a hemorrhage. Also, a hemorrhage can be related to retained placenta fragments. And so say that placenta, the baby came quick, and now the placenta and then the placenta, the uterus may stop contracting, and then you have pieces of placenta still up in the uterus. And so, and if she delivers, say, outside the hospital setting, you might miss that she had a placenta fragment still up in the uterus, and that can cause massive amount of bleeding and cause a hemorrhage. So you see, precipitous labor and birth it's not the best either. Okay, so that's why you have to be on alert to all these complications that can be related to a precipitous labor. Now, when you have a precipitous labor, just want to go over, you have what we call hypertonic contractions. And that can be when you have a placenta abruption, you have these type of contractions. And that's why, again, you can have when they have a placenta abruptio, is that because of these hypertonic contractions, okay, the placentas can abrupt right off that endometrium. It kind of makes sense if you think about it. And then, because this is another term for hypertonic, is called uterine tachysystole, and that is hyperstimulation of the uterus. Now, if she comes into your unit and she's having uterine tachysystole, and you suspect maybe an abruption, it could be that she just had a recent cocaine use. Cocaine can make this happen also. All righty. So that, again, is called the precipitous labor and birth. Remember, labor that lasts less than 3 hours from the onset to the time of birth. Very, very quickly. Okay. All right. Another area that we're going to discuss is indications and contraindications for induction of labor. Now, this is always a good all that apply question. Okay, so kind of take note, and these are in your book. And so indications. Now, if I'm going to do an induction of labor, there's got to be a reason, okay, that we're going to induce her. So she could be that she could be sick. She could have gestational hypertension. Better to get the baby out, because remember we said with preeclampsia and gestational hypertension, I mean, the cure for preeclampsia is what? Delivery of the baby. And they have this research that relates this preeclampsia back to the placenta being the cause. And remember, preeclampsia happens in the younger people, the 17, 18, 19 age group, and then the young, 19 and younger, and then you have it in the older, the advanced maternal age patient that is above 35. They seem to get that preeclampsia. So indications for an induction would be the hypertensive disorders, infection within the uterus. Yeah, if she's sick, we want to get baby out, get mom taken care of. So that would be another thing. Medical problems in the woman that worsen during pregnancy. Yeah, you want to, it's no good. Let's get it done. Maybe she's got diabetes, and so we want to go ahead and get this baby out. Because with diabetes, they're so prone to having large babies, and especially if she's been not under good control, then babies just are getting bigger and bigger. Fetal problems, such as a slow growth. Baby is just in what we call a hostile environment. I don't know if you heard that term at all, but that's what it is that the uterus is no longer being conducive to fetal growth. And so it's time to get the baby out. And then you have, of course, the prolonged pregnancy that we just talked about. And then you could have incompatibility between the fetal and maternal blood types. Yeah, that RH incompatibility, or the RH negative mommy has her blood mixes in with the RH positive baby. The mommy's RH antibodies will eat up the erythrocytes of the fetus. And so what happens is the baby then is anemic. And so we want to get that baby out so the baby can have a chance to get a blood transfusion. All right. And then you have placenta insufficiency. And this is related to, on the monitor, you will see late decelerations. And you can see that the placenta is no longer doing its job. It has decreased. And so therefore, the baby is at jeopardy. And so we have to get the baby delivered. And then, of course, unfortunately, you have an indication for an induction would be fetal death. The baby has now expired inside the uterus. And you discovered that when you either check in fetal heart tones or you do an ultrasound, and there's no more fetal heart rate. Okay. All right. So those are indications why you would start your Pitocin and you would do an induction of labor. Okay. Now, you say, on the other hand, there's always indications, always what we call a contraindication. And so these are things that you would not do an induction. So the first one on the list here is placenta previa. And we went ahead and discussed a little bit about that before when I discussed about placenta previa. You cannot induce a placenta previa. She will bleed to death on you. So we don't do induction. We do not do an induction on umbilical cord prolapse. The cord is prolapse. So the cord is presenting down in the birth canal. And you would never do an induction. You kill the baby. Okay. And then you would not do an induction on abnormal fetal presentation. That would be, we don't induce on a breech. No, we don't induce on a transverse lie, which could be the shoulder presenting. Do not do an induction. Again, you would hurt the baby. So on that, so no. And it wouldn't be successful either because you can't get a shoulder through a pelvis. Okay, so that makes sense if you think about it. And then active herpes, infection in the birth canal, I would not ever induce an active herpes. So no. And then an abnormal size or structure of the mother's pelvis. So you would not do an induction of labor on someone who has a plantoid pelvis because it just wouldn't be successful. So remember, the most successful is the gynecoid type of pelvis. So this is a plantoid, even anthropoid. It would be a abnormal structure. And so again, when you're doing an induction of labor, you want to be successful. And then if you have a previous classic cesarean incision, you cannot do an induction. And also, you cannot give Pitocin. Now, when you do an induction of labor, what that is you're getting her Pitocin. I'm inducing. I am mimicking labor by using the synthetic form of oxytocin. And so I have to be careful because you can never give Pitocin to a VBAC. And remember what that stands for, a vaginal birth after cesarean. And so you can't give her Pitocin, so you cannot do an induction. All right, because she has to go into spontaneous labor. So be careful on those kind of questions because that's how they kind of trick you on that. So again, you have to know what an induction is all about. An induction is administering Pitocin to what? To stimulate labor. Now, there are other means of an induction, but that's the main one is with the Pitocin. But you can induce labor on a patient by sending her out walking, and that's in your book. And so but she can't, she can walk to a certain extent and then she gets tired. And then another way you can induce labor is nipple stimulation. But nipple stimulation we don't use that too much in the labor room because we can't quantify it. That means I can't measure how much oxytocin is being delivered to the uterus from the pituitary because I can't. So that is a little difference. But in the labor room, what we use is Pitocin. Okay. Again, your patient, imagine your patient in the labor bed, and she's got the fetal monitor on. Always, 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 when you do an induction of labor, you always monitor the fetal heart rate. Okay. And then I got the Toco, which will measure what? The contractions. So I got my monitor on mommy. And then I got my blood pressure machine, the blood pressure cuff on. I got my pulse oximeter on. And I always have oxygen readily available on my back wall. And we always deliver oxygen 8 to 10 liters via face mask in the labor room. And then and then she can induction, we start out slowly. We don't put somebody into labor like wham bam, no, it's in milli-units. Okay, so that's the indications and contra indications for induction of labor. Okay. All right. So now, hopefully, we're going to go over the process of labor. Okay. So in a few minutes, I'm going to pause my recording and I'm going to give you all a little break. Okay. So process of labor. Signs of preceding labor. What happens beforehand? Okay. Well, mom could be experiencing lightning. What's lightning? Lightning is when the baby drops. Okay. Ooh, not great. All right. So lightning is dropping. Okay. I would take that into consideration. Braxton Hicks. Now listen up. Braxton Hicks are irregular contractions. Okay. And so, they could be 5, 6, 7 minutes apart. They're not regular contractions. they're irregular contractions, and they can be annoying, okay? But again, this is all maybe before she goes into true labor. And then you have increased vaginal mucus, and which is a good sign. And then you have cervical softening, where the cervix will actually soften up. And then you could have possible rupture membranes. And so remember, if she has SROM, that is spontaneous rupture membranes, the first priority of that nurse is to put the monitor on, listen to fetal heart tones. I have to know that my baby's okay, because she could have SROM, and it could be that the head of the baby was high up in the pelvis, like a -3 station. And so that could put her at high risk for a prolapse cord. So I would definitely want to listen to baby's heart rate right away, guys. Okay. And then if she does rupture membranes, we take note to the following. We want to know the color, so it should be clear. And we want to know the amount. And I want to know if it had a smell. Okay, the reason why is because if it has a smell, okay, listen up, it has a smell, that's an indication of infection. Okay, never good. If it's not clear and it has like greenish brownish fluid, that means the baby had his first bowel movement inside, so he had meconium. So now you got meconium fluid. And I want to know the amount, because it's very important, because if she labors a very long time, and I have to know that, because she could, if she had lost a lot of fluid, she could go into what we call oleohydramnios, and that can cause her to have vertibles on the monitor. That means the baby's heart rate goes down, goes down and comes right back up, but it's called vertibles. Okay, and that's caused by cord compression. Now, bloody show is a sign that mucus plug has released itself from the cervix. Bloody show is a good sign, because it's mixed with blood and mucus, and that means that the cervix is starting to open up. And the cervix is a very vascular area, so when it starts to open up, it sheds. It'll shed that blood, and that's where you get the bloody show. So that's pretty good. I like that. That's always a good sign. So again, signs of preceding labor would be lightning. We have dropping of the baby, Braxton Hicks, irregular contractions, increased vaginal mucus, cervical softening. Okay, cervix is starting to open up, possible rupture membranes, and then the bloody show. Okay, so those are all good. All right. So let's do this slide, and then we'll take a break. Now, what is labor? All right. Well, we've been talking all about this. So now this is labor, onset, and stages. Please take note and know the stages of labor. These are always good questions, and Hesse likes them too. So what you want to do is, first of all, we're going to define labor. So labor is defined by regular contractions and changes in cervical dilation and effacement. You have to have that. That's when she's in true labor, is when she has regular contractions and changes. See that changes in cervical dilation and effacement? That's what's important. Okay, so these are the stages. In total, you have 4 stages of labor. The first stage is your longest stage, because it has 3 phases. Now, the first stage is classified as onset of labor to when you reach 10 centimeters. And then what happens if we broke that stage down? Because there's a lot that goes on during the first stage of labor. So in the very beginning, you have what we call the latent phase. Now, another term you may see in a book, it could be called the early phase. And so what it is that you do have some dilation and effacement, and you dilate. So you start out from 0 or 1 to 4 centimeters, okay? And so basically what happens is that is the early part. Now, in the latent phase, you want to use non-pharmacological means of relieving pain. So when I say non-pharmacological, that means like skin stimulation or hydrotherapy, sacral pressure to the sacrum, relaxation, massaging. Oh, another big one is effleurage, where mom puts her hands on her abdomen and she just massages her belly. And that's really relaxing. You sit them up in a chair. And I usually always put a nice little blanket underneath that rocker, put her in a nice rocker. And she can do the pelvic rocking and the effleurage. And that really helps them to relax during this latent phase. Because I don't want to give medication to someone in the latent phase. Because why? Because she just started, all right? And I don't want to slow down anything. So we're going to keep mom and dad or her partner really active during this time. You can use also diversion to divert her attention away from the discomfort that's being produced by the uterus and get her mind off it. Sometimes I tell the daddies, you know any jokes? Start telling jokes. And it's really kind of interesting interaction during that time. All right. And then in the room too, as long as she's not on any kind of Pitocin or anything, she could be up and walking, as long as her membranes are intact. She could be up and walking around and stimulate more contractions. Okay. Also, a lot of times I put my patients in a shower and let the warm water run over her body. And that really relaxes my patients. And so, those are things you can do in the latent phase. All right. And now also, let me just put this in there. In the latent phase, I'm assessing her ability to breathe with contractions. Now, even if she went to childbirth preparation classes, a lot of times this is where they forget how to breathe. So I want to make sure that she's breathing properly with every contraction. So I would go over the slow chest breathing during the increment of the contraction. And at the acme or the peak of the contraction, I would review with her the more like he blow to get her through that acme of the contraction, and then go back as soon as that contraction lets up and it goes down on decrement. Then I would have her reverse back to what? To a slow chest. Now, this is where I take the time to assess and reinforce her breathing. Now, then she goes from the latent phase. So now we're going to dilate. Now we're going to about 4 to 7 centimeters. So that cervix is opening up. She probably has completely effacement of that cervix. And now that baby's dropping. So is she going to feel discomfort? Yes, she feels more of the baby coming down, and the contractions will increase. They'll increase in the intensity and duration and frequency. So this is where if they want to have their epidural, that's kind of a good time to have an epidural. If she's not wanting an epidural and she wants to have a narcotic, this is the time that you would give something. Now, the difference between giving a narcotic versus an epidural is that the narcotic does not take away the pain of the contraction. It does not. What happens is that after the contraction, she's able to relax and to let her body go so she can get ready for the next contraction. Now, the epidural, though, that's a form of anesthesia. And so she can be anesthetized from the waist down. And during that time, that's a really good time to make sure that, everything is good. You have her on the monitor. She has an epidural, and now she just labors, and she doesn't feel it. Sometimes they have a little bit of pressure, but not too much. So they get a good epidural. And this is the time, too, if they've had a long latent phase, that they can rest. So the active phase is just like it sounds like, is active. All right, there's a lot going on. And so you have, again, more rapid dilation. Now we go from the active phase, we're progressing now to the transition phase. Well, this is just like it sounds. We're going from 7 to 10. Okay, so during this time, baby's dropping more. So if she does not have an epidural, they feel that head right there and have a strong urge to bear down. So what would you tell her? You don't want her to push prematurely. They have to be 10 centimeters to push. So what I would do is if she has this urge to bear down, I would have her blow out in short puffs. What I usually tell my patient is look at my finger. I hold my finger up, and then I would say, imagine that's your birthday candle, and blow out the birthday candle, and they have to puff their cheeks up, see? And when you do that, you can't push at the same time. And that really does work. So that we would tell her. So I would take note to that. So again, 7 to 10 centimeters is transition. Now, this is the time that you do not give a narcotic, because it goes, remember, everything that you give mom goes through the placenta and goes right to baby. So I wouldn't want to give a narcotic, because the baby would come out, what? Sleepy. But if you did give it, and the baby came out sleepy, you always have Narcan at bedside. Okay. Now, during this transition phase, if she had an epidural, okay. So first of all, you don't start an epidural during the transition phase. Well, because I'll tell you why. Patient comes in and she's 8 centimeters. That means she's been contracting. She only has 2 more to go. And she's been handling the contractions all that time. So if you gave the epidural during this time, then she would have what we call a fresh epidural. And when it came down to she became 10 centimeters and she had to push, she would not feel that urge to bear down, because they don't have it. They anesthetize. So therefore, that's not the good time to have an epidural. And during the transition phase, if they had the epidural ready, then I usually call anesthesia, let them know patient now is completely dilated, and they give me an order to decrease the epidural pump, or they'll come up to the unit and decrease it for me. And so then she gets a little bit of sensation back in her bottom so that she can push. Okay, so that works out good. So you can see that you have to time these different phases correctly so that you give the best labor to your patient. And if your patient doesn't want any pain medication, that's fine. You respect that, and you help her get through it, her and her partner. And then, but you can see the difference in the phases. So again, latent phase is the beginning, and is from like 0 to about 3 centimeters. And then active phase, you go from 4 to 7. This is more rapid dilation time. The contractions are very strong, and the frequency should be like every 2 minutes. And then you got the transition phase. The contractions are strong. The baby's coming down. Mom can feel the baby move down, and she might have that urge to push. And you cannot don't let her push before she reaches 10, because you could make that cervix edematous, and it's never good to have a swollen cervix. Okay, so that was the first stage of labor. All right, a lot going on. Now, she becomes 10 centimeters. Yay! All right. And now she's in the second stage of labor. So she's fully dilated, and now we're pushing. All right. So this one can last up to 2 hours. It's all according to how great she pushes. Now, I love when have a mom that's been exercising or walking, and she's got a strong pelvic muscles, and she can push that baby. And some women just can't push the baby. So what happens is that you could have like a latent and a passive descent. And if she has an epidural, we don't push unless they start to feel that we call that friendly pressure. because it's just a waste of time. So we let the baby descend on his own, and we just basically we watch the monitor and make sure the baby's heart rate is just fine. Then, so that's more of a passive descent. Yeah. And there's no sense if you have an epidural in place, and she and it's a good epidural per se, then she wouldn't feel that to push, no matter how hard you try. And what happens is you're going to exhaust your mom. They get very tired, and so we just go ahead and let the baby drop. Until she starts to feel more pressure. The epidural starts to wear off a little bit on the bottom. Then the next one is active pushing. And mom is right in there pushing, and we always say, just feel, how I told my patients, because they say, how do I push? How do I push? Am I pushing right? And what I say to them is, think that you've been constipated for a couple of weeks. Oh, that's not a bad picture. All right, but you get the picture. And I want you to push like you're going to have, big old bowel movement. And when they do that, I get the baby just come right down beautifully into crown. And I just love it. So you have to give sometimes these visions, these pictures to your patients so that, they know what to do. And then, second stage, again, we already talked about the epidural. And then during the second stage, when she's about to deliver, the doctor can do what we call a pudendal block. And what they're doing is they're numbing the pudendal nerves. And so that's, remember, the anatomy, and so it kind of deadens that perineum in case that she needs an episiotomy, is that she doesn't feel it. Okay. And so those are the different types: pudendal block, and then you have your epidural. All right. Now, in your third stage, okay, so that was the second stage. Okay. Now that stage, there's a lot of work going on. And then third stage is now birth to delivery of the placenta. The placenta is very, very important to get out, okay? Because if you don't, she can hemorrhage, bleed to death. Okay, so we're going to deliver that placenta. It has its own little stage. All right, and when the placenta comes out, you want to look at the placenta. So we have two sides of the placenta. We have the shiny Schultz side, which is the newborn, and then we have the maternal side, which is kind of looking like it has a whole bunch of lobes. And I know there's a great picture in your textbook, and you can see all the different lobes of that. That's where it was implanted in the upper portion of the uterus on the posterior wall. So what you want to do is you want to look at that. And the reason why you want to look at that placenta is the mother side is called the Duncan. And how I learned it years ago, Dirty Duncan is mom, Shiny Schultz is newborn. Okay, so the Dirty Duncan, you look at it, has all the lobes, and I want to make sure that every piece is there, because what am I looking for? I want to make sure that nothing is missing. It's all intact. Because why? Because a piece of that placenta could be in the uterus. And so that would be placenta fragments, retained placenta. And we don't want to retain placenta, because then my patient will bleed. Okay. So we want to make sure that the placenta comes out intact. And then the fourth stage of labor is the first 2 hours after birth. Now, a lot of times that we say the fourth stage of labor is almost like the fourth trimester. You know what I mean? But for right now, the fourth stage of labor for you guys is the first 2 hours after birth. And that is during the recovery. And that's a very important stage. You want to make sure you take mom's blood pressure, heart rate, pulse oximetry, and make sure the fundus is firm. Now, if she has a boggy uterus, what are you going to do? You're going to massage the fundus. So you take your hands and you kind of cup them, and you have one hand on the top of the uterus, the fundus, and the other hand on the bottom, and you actually have your patient's uterus within your hands. And then you'll massage massage that, okay? Massage the fundus. And you'll see the uterus actually come really up and come firm, and then you know you've been successful. So you can't just say, oh, she has a soft bulb uterus. No, she will bleed. You'll see a lot more blood coming out, and you know something's up. So these are the 4 stages of the labor process. Okay. And, again, the first stage, and she's contracting and she's hurting. All right. She's just starting. Okay. And then you get a little more, and then don't forget, you have the different phases, and each one of them has their own indication. Okay. So that takes care of labor. Now, uterine contractions. Now, you remember the 4 P's of the labor process. So you got the power, that's your uterine contraction, the power. Contractions are important. Okay, that's how mom effaces her cervix and she actually dilates. So you have to have contractions. And so we want to make sure she does. And then we want to monitor her contractions. We don't want her to have hyperstimulation or tachysystole, because that can cause a problem, correct? We already talked about that. So I'm going to look at frequency, duration, and intensity. So write down frequency. So frequency is the timing beginning of one contraction to the beginning of the next contraction. That's frequency. Now, nice frequency is like 2 to 3 minutes apart. That's a nice one. Okay. And then duration. Duration is how long they're lasting. Okay. So it's timing from the beginning and end of the contraction. So it's how long they're actually lasting. So remember, on the monitor strip, you have the boxes, and you have 2 solid lines, and then you have 6 little boxes. And so each of those little boxes is 10 seconds. So then you would count. So 10, 20, it'd be 60 seconds, which is a minute. And so what you're doing is you're looking from the beginning of the contraction. I'm drawing, you see my hand going up, beginning of the contraction, right? To the end of that contraction. That's my duration. How long is lasting? Now, I like my contractions to be from 60 to like 90, not greater than 90 seconds. 90 seconds is a little long. So that's what we want. We want the beginning of that contraction go up, right? You have increment, we have the acme, and we have decrement. That one contraction is how long is lasting. So we have frequency, where we time them from one contraction to the beginning of the next contraction. Okay, that's frequency. So that's why you have from maybe 3 minutes apart, 4 minutes apart. You're looking at that. Then you have duration, how long that contraction's lasting. So then I would count my little boxes. It would be 10, 20, 30, 40, 50, 60. Perfect. Okay. And then the next, I'm going to palpate. Now, this is by external monitoring, where I'm going to palpate the intensity. And how do I palpate the uterus? I'm going to take my 2 fingers, and I'm going to just use the top, and I'm going to gently, when she has a contraction, I'm going to gently put it on the fundus of the uterus, and I just can feel how strong they are. So we chart that as mild, moderate, or firm. Okay, in the beginning, the latent phase, it could be mild. Then as she gets into the active phase, it gets more moderate. Okay, moderate to firm. And then on the transition phase, it would be more what? It'd be more intense. Okay, be firm. And that's how the labor process goes in the contraction, because what happens during the contraction, the baby has to actually hold his breath. So you can't have that, and whatever residual, whatever he has left, he's using. So you want a baby that's healthy, he can handle these kind of contractions but a baby that's sick would not be able to. All right. And I have a little drawing right here, as you can see, and you have these in your book too, where it's about contractions and what I just said. So I'll just read it to you. In more normal spontaneous labor, spontaneous, so it's not an induction, contractions occur with a frequency of 2 to 5 minutes, and they may last between 30 to 90 seconds, not greater than 90. Remember, I just said that. And durations greater than 90 seconds do reduce the fetal oxygen supply. So if I have a healthy baby and I have these long contractions, I can make that healthy baby sick inside. So I don't want to do that. I don't want to compromise this baby. And so we want to make sure. So let me go down to this picture and you can see the contractions. So how you would do your frequency, beginning of one contraction to the beginning of the next contraction. And then duration would be those little boxes I talked about. So you can count, so 10, 20, 30, 40, and they'll go from 40 to 60, and it's just perfect. So those are contractions. And I already talked about uterine tachysystole. It's just too many contractions. So it's more than 5 contractions in 10 minutes, or a series of single contractions lasting what? Greater than 2 minutes. Hyperstimulation, not a good thing. We talked about that. Okay, so that kind of shows you contractions. Again, is the power. You need to have contractions. All right. Now I'm going to stop here for a minute. I'm going to give you all a break. So I'm going to stop recording. And let's see here. I'm going to stop sharing. I'll come back to that one. All righty. And we'll pause the recording.